39 plus 2 weeks with Nelly Gravita in this in labor 6 centimeters and CTG showing recurrent late decelerations for the past 20 minutes. Now, do you note that something unusual which is not mentioned in other scenarios is given here? Oxytocin is ongoing here. Okay, when such a clue is there, right? Okay, then what are you interested in knowing here? Recurrent late deceleration for the past 20 minutes. Primary 6 centimeters with oxytocin. Don't you want to know indication why this oxytocin was started, dose at which it is, contractions which are ongoing? Because when you talk conservative management, okay, what are your conservative management? One, is it oxygen? No. Okay.
Stop
You are
oxytocin.
going to see if dehydration is there, then you'll start fluid. If it's because of post epidural and hypotension, then you start fluid. You have to know this inside out. There's no excuse for not knowing nice guideline. Okay. The third is you put in left lateral. So you think that supine hypotension is playing a role there? And the fourth is if there is hyperstimulation, okay, so the either tachysystole or hypotonus. What is tachysystole? More than 5 contractions. Hypertonus, contraction which is lasting more than 2 minutes. If these are there, all right, then you want to reduce the or stop oxytocin at this point of time. Hmm? So I am interested in knowing why this woman got recurrent late deceleration. So when I say that uh, do full assessment of the woman, what full assessment of the woman are you looking at? You're looking at the basic causes why this will happen in nulliparous woman. Specifically when oxytocin is ongoing in this woman. I want to know this about contractions. So confirm the CTG trace pattern, oxytocin dose and indications, color of the LICA, other concerning CTG characteristics, any antenatal high risk factors, because I won't treat the CTG by itself, whether it's amber, red, white, whatever it may be. So, further information examiner tells you there are 6 contractions in 10 minutes, but the liker is clear. So, liker is nothing to write home about or worry about. But we have a cause. So, my conservative management here is what is it? What do you want to do now? Hello. Okay,
Stop
let's at least.
oxytocin, ma'am.
Yes, who said that?
Shilpa.
Evelyn.
Shilpa. Okay. You want to stop oxytocin? You want to review? Okay. What happens after you stop oxytocin? Two things can happen. Either the fetal heart rate will go back to normal, so the CTG will become normal, or the CTG will persistent and remain the same way and be classified as pathological subsequently, right? So it becomes more than 30 minutes, it will become classified now into pathological. So if it becomes pathological, then we may have to decide further. Okay. If no improvement, then expedition of birth may be considered. But if there is CTG improvement after stopping the oxytocin and reducing the number of contractions, then um, I may reconsider starting oxytocin at a later point of time, only if she agrees to do so, and if consultant review finds that it's acceptable. Okay, so I will do that. Hmm. Hopefully, my conservative management here. What is the question asking you? Question is asking you. Intention of the question is, you know what to check, and you know immediately if that is given to you, like a tachysystole is given to you. Do you know the management of tachysystole in a woman? That is the intention of the question. Okay, nothing further than that. In APH, what do you know what to look for? You know what to look for now. We tell you not bleeding anymore. What should be done now? Next question. Fever 38 degrees Celsius. CTG is pathological. What do you look for? You look for signs of sepsis. You need to ask me about them, not assume that they are there. Hmm? So I would like to see maternal observations, pulse, blood pressure, signs of any infection, foul smelling, liquor color, also. And then I tell you whatever is given in the bracket here is further information. So there was meconium, and there is maternal tachycardia and hypotension. Now you know it's sepsis. Okay, so suspected chorioamnionitis with sepsis. I would like to employ the sepsis 6 bundle. Okay, or rather, my bad, Sepsis 6 bundle will be employed, and you need to enumerate all the components of sepsis 6 here. And the expedition of birth will be considered if the CTG abnormality persists despite correction of the temperature. Okay, if the fever is corrected and all those thing is there. So we will involve the consultant in the decision making here. This is urgent. Okay, urgent room, because sepsis, all everything that you're doing, employing the bundle, etc., needs to be done within a set time frame. You don't have much time to waste. Hmm? So at the end, if I am allocating the two, I would go myself here. That would be a better thing to do. Sending the HT3 for room number 1, where they would assess and stop the oxytocin, for example. Okay, so that they can do that and continue monitoring. Then we go to room number 4. Okay. Since second stage of labor with a gestation of at 40 weeks. Okay, multi. Now, please note epidural is in place, so we've got some time. But they've been pushing for 60 minutes and the head is now descended down. CTG is still normal. What should you do in this case? It's like what's the normal thing? It's the same as in the previous question actually. Okay. Epidural is in place. Okay. But pushing for 60 minutes has not brought her very close to delivery. It's still at +2. You want to assess and see whether the progress has been adequate in the last 1 hour. So what happened? Did she descend, rotate? What happened there? All right. So the senior midwife goes there, assesses her in the full view of that. This is what is helicopter view. Helicopter view of her second stage of labor actually, and sees for head descent, maternal efforts, contraction, passage, all those things. And so then I tell you that she's been full since the last 1 hour, since when she's been pushing, and there's good contractions, but minimal descent in the last hour. So once you know there is minimal descent in there, she performs an ARM and waits. Okay, waits as in, then if there is no progress, then she will be diagnosed with the delay and may need to expedite birth by an instrumental delivery. This is the line of management. Hmm? Room number 5. Okay, room number 5. Pretty much the same, except that the only difference is that, okay, room number 5, is she for delivery or is she conserving? Opinion poll. Are we conserving her or are we delivering her?
We need to get the further findings whether her blood pressure is under control or not, ma'am, and any imminent signs
That's
does
what
she
I was
have.
trying to say when the mic was actually echoing. BP is 170 by 110.
Mm.
She has got, I said that she had got, I don't know if you guys caught that, but I
And
mentioned she had
Yes,
headache.
she's
And,
having
yeah.
headache.
Mm.
we won't be delivering her. She's 30 weeks and the neonatal unit is full. We have to stabilize her and transfer her.
No, that's the trick. The thing is, she might convulse while you are transferring her. You have to deliver her and ex utero transfer the baby. There is a reason it is put this. The placenta
Okay.
previa, you arrange a transfer in utero because it's possible, but where it is unsafe to transfer the mom right now, okay, because she's not stable enough. Is she good to go? Something happens to her, then it's a risk, right? So, what I was going to tell in further info, which I did, was severe headache and blurring of vision. Blood pressure is 170, urine albumin is 3 plus. She is in no condition at 30 weeks to be transferred with all of this. She's very, very imminent and she's like ticking like a bomb. So, this is the information she should ask me, which we have discussed last time also. This is the information she gets. Not in a stable enough situation to arrange transfer and then have that section done there. So the safety thing here would be that you do here stabilize her, keep her there, keep her for monitoring, but you would need to ex utero transfer the baby. Okay. It's not possible. You don't have a choice in that. Sad situation, but no choice. Okay. So let's go to the other rooms, which is room number 6, 8, 9, and 10, which is pretty much we back in latent phase. Nothing great to be done. We have seen this one.
Ma'am, your voice is
And
breaking.
hello, hello. Better? Hello. Voice good? Hello. Can I get a thumbs up? Okay. Alright, so we
No,
have
it's not good. Your voice is breaking.
this. Okay. My neck is the same. Okay, just show the slide to you in that case. Rather. Okay, further information was later phase of labor, it's nothing urgent. And in room 8 as well, there is nothing active happening as such. Induction has already been started, just that the CTT would continue to be kept for her. She's para 3. She's not contracting. You keep on monitoring because prostaglandins have been put. You reassess at the appropriate time for her, and you are going to continue with the induction. Not urgent for you to see right away. Okay, post dated and age is also high. You need to then you may speak about the associated risks have been discussed with her or not. Okay, but the right now current management is monitoring, continue monitoring. This management was also correct. Reduce fetal movement. Alright. Might be non-urgent. Send a midwife. She's 28 weeks. So what action are you going to immediately check? Other than you need to ask if fetal heart rate is heard or not heard. Examiner says yes, heard, but there is reduced fetal movement. You need to say what exactly you want to know. The history of movements in the past, as you said. Any other complaints are there? What was the with the Doppler? If there are any other high risk factors for fetal growth restriction, because if there are high risk factors for fetal growth restriction, or if the reduced fetal movements are persisting despite a good CTG, then they are for a growth scan. Okay, a growth scan. But at this point, for a 28 weeker, you're not going to consider immediate delivery and things like that. Okay, the examiner tells you baby is alive, okay, alive and kicking, so things are fine. You don't do urgent anything. Lastly, postpartum 2 hours with a blood loss of 500 ml. Why MOH here? Why? What was the need? 2 hours ago, she bled total 500 ml. Is she bleeding now? Did you ask me that? No. Okay. So I have to say blood loss, estimate vitals now, tone, was there any trauma? Upon further information, you are told there is no ongoing trickling, uterus is firm, placenta is complete. Send a midwife there. She needs to just monitor and debrief that there was some bleeding which occurred, but nothing major. Okay, so it's very, very minor. It's 500 ml for the minor PPH category. Okay, just because some bleeding is seen, the question doesn't mean that you need to jump on it and do something about it. Okay,